All right, we'll go ahead and get started. Hi, everyone. Thank you for attending our second webinar in the home healthcare series. Today's presentation is titled Spatial and Temporal Assessment of Secondhand Cigarette Smoke Exposure to Home Healthcare Workers by Judith Arthur. Judith is a third-year Ph.D. candidate in Industrial Hygiene at the University of Cincinnati, where she trains in aerosol and exposure science under Dr. Sripriya Nannu Shankar. Her research involves combustion simulations of secondhand smoke and evaluations of combined exposure control strategies. Her doctoral work focuses on emerging issues related to bioaerosol emissions from wildland fuel combustion, with the goal of strengthening exposure science and informing occupational and environmental policy. I'll now hand it over to Judith. Thank you so much.
Yeah, thanks for having me. Hello, everybody. I guess I don't need to introduce myself again. We'll just go straight to the point. So, I hope we have some home healthcare workers joining us today. It will be pretty much exciting to know that this webinar is going a long way to improve exposure, particularly when it comes to secondhand smoke emission. So we will first of all start off by kind of refreshing our memories to know who exactly home healthcare workers are. So these are skilled professionals trained to administer medical and nursing care to individuals in the comfort of their homes, okay? And they include physiotherapists, occupational therapists, nurses, medication aides, and healthcare aides. Now, currently in the US, they are among the fastest growing professions with a projected growth rate of about 29.9% by 2029. But then here's something interesting about them. Now, unlike their other colleagues who happen to work in structured hospital settings with easy access to sophisticated machinery, guidelines to report hazards, and economic training, oftentimes they're not. Home healthcare workers find themselves working in unique, unpredictable, and unregulated environments, ultimately exposing them to occupational injuries and hazards such as extremes of temperatures, chemical exposures, latex, needle stick injuries, musculoskeletal injuries, mental stress, violence, and exposure to tobacco and secondhand smoke. Now, amongst all these injuries and hazards, we are most worried about their exposure to tobacco and secondhand smoke. And the reason is that most often than not, when home healthcare workers go to the homes of their clients to administer their services, either the client or a family member or relative or a friend may simply not stop smoking even in their presence, thereby exposing them to these emissions. Now, secondhand smoke has several names, okay, probably depending on where you are coming from. So some people call it passive smoking, some people call it involuntary smoke, others also call it environmental tobacco smoke. We are all speaking the same language, okay? So it's actually made up of two streams of smoke, the mainstream smoke and then the side stream smoke. Now, the mainstream smoke are simply the emissions that you usually see being exhaled by the consumer or the user. And the side stream smoke are the ones that emit from the burning end of the lit cigarette. Now, there are three main ways by which home healthcare workers are exposed to these secondhand emissions. One, occupants smoke during their visits. Simply, we are saying that when they go to the houses of their clients to administer their care or service, they will be smoking and there's nothing they can do about it. Or prior to their visits, apparently 20 or 30 minutes before they visit their houses, the clients or their caregiver or whoever might have smoked, and we have some lingering effects, thereby exposing home healthcare workers to it, even when they come in 20, 30, or even 45 minutes after the activity has ceased. And the last bit is smoke drift in from other rooms from the neighbors. So probably you are visiting a client in a complex where either a neighbor before or after him is smoking, and you have these emissions creeping into crevices and then coming to where services are being rendered. Now, there are several misconceptions when it comes to secondhand emission, either from traditional cigarettes or from electronic cigarettes. Okay. But then let me debunk this. There is no safe level of exposure, and even acute exposures could result in adverse physiological effects. Okay. Quickly, we would refresh our memories about likely impact of exposure to secondhand smoke. Now, per evidence, secondhand smoke contains more than 7,000 chemicals, okay? May include benzene, formaldehyde, baridium, and chromium. Many are known carcinogens. That means they can cause cancer, okay? And according to CDC, exposure to these emissions increases the risk of coronary heart disease by 25 to 30%, and that of stroke by 20 to 30%. It's also been linked to some cancers like the lung cancers, and it's also been linked to some reproductive health issues in women, ear infections, asthma, and respiratory infections in children. Now, statistics revolving exposure to home healthcare workers is amazing and worrying, okay, in the sense that more than 1.3 million of the world's population die annually from these exposures. Okay. And for us in the US, we also know SPED. About 34,000 non-smoking adults are also exposed to secondhand smoke, or they die from exposure to secondhand smoke arising from heart-related issues. And that brings to mind this amazing question I've always entertained. I don't know if some of you have also entertained this idea that if it's ever possible to live in a world where we are not exposed to these toxic emissions. Now, something interesting about secondhand smoke is that indoor secondhand smoke can persist for a long time, okay? Particularly when ventilation is poor, and they can infiltrate into adjacent areas to also cause harm, either through the cracks in the walls or through ventilation ducts or through electrical outlets. Published guidelines makes us know that even smoking one cigarette can persist for several hours. And most often than not, people think that, oh, once we put on the fan or we distance ourselves from the source, we are safe. But then per guidelines, all these mechanisms are sometimes not protective enough to protect us from all these exposures. So the best thing is to more or less abstain from all these emissions. And again, is that possible? We live to see. So currently there's this rising trend in electronic cigarettes, which is also quite worrying. And for me, what makes me worried is the fact that you have so many adolescents, young adults, teenagers, school-going kids actually engaging in in the usage of electronic cigarettes. And you really can't blame them in the sense that it's a very good marketing strategy that is being used. It's being marketed as a safer alternative to tobacco smoke, okay? Particularly for individuals who are looking forward to quitting and are still struggling. These marketing industries or firms make it look like, oh, this is relatively safer than the tobacco smoke. So for someone who is looking to, quit, this is a much better alternative, okay? But then one thing they fail to mention is that these electronic cigarettes also produce aerosols that are rich in volatile organic compounds, ultrafine particles, nicotine, and then heavy metals. Okay. So relatively, when you compare emission rates between traditional cigarettes and then electronic cigarettes, yes, electronic cigarettes produce, far fewer emissions, but that does not take away the fact that they still can impact indoor air quality and can impact health. Current research or literature have been able to link exposure to electronic cigarettes to some acute respiratory issues. However, there's currently a growing body that is trying to establish a link between long-term effects or long-term impact of exposure to electronic cigarettes. Controls. Let's talk a little bit about controls. How do we protect ourselves? How do we protect vulnerable individuals? How do we protect home healthcare workers? For those of us in industrial hygiene or occupational health and safety, usually our go-to framework when we talk about controls is the hierarchy of controls, okay? The hierarchy of controls is just an inverted pyramid with the most effective control found at the top and then the least effective at the bottom, okay? And so that is the framework we are going to employ to talk about control, some ways we can reduce or limit exposure. First on the list is elimination. Elimination continues to be the most effective way by which non-smokers, vulnerable individuals can be protected against emissions. And this can be achieved through establishment or enforcement of comprehensive smoke-free environment. But currently there's an issue with this policy in that current smoke-free policies do not include the usage of electronic cigarettes. And so as it stands now, more than 80% of the world's population and about 40% of Americans are still exposed to some form of emissions, either from traditional cigarettes or from electronic cigarettes. Next, we are talking about substitution. Substitution is simply replacing a hazardous event or toxicant with one that is less hazardous. And I know this is the place where people will say that, tada, it means that electronic cigarette is a better option because tobacco or traditional cigarettes produces more emissions than electronic cigarette. And so when you are talking substitution, that should be a better way to substitute. I mean, I will applaud you, or I will say that the ideology behind the explanation of using that as a substitution example is right. But that is not what we are trying to project here. That is not the image we are trying to project here. So we are saying that for individuals looking forward to quit, do not switch to electronic cigarette. Instead, you could indulge yourself in some nicotine replacement therapies instead of actively, smoking either the electronic cigarette or traditional cigarettes. Next is engineering controls, where we are thinking of improving, circulation or improving ventilation in wherever the exposure is taking place. Now, whilst this method may help to a certain degree in diluting these pollution, as already mentioned previously, these standalone methods are just not sufficient to adequately offer protection against this emission, okay? So again, the number one rule is to eliminate if possible. Next is administrative controls, which involves basically using education to talk to people about, or educating them about the ills of exposure or the ills of indulging either traditional or electronic cigarette. And that is exactly what I'm doing here, communicating the impacts, the statistics, the temporal and the spatial distribution and how it impacts our well-being. So either using education to talk to people, or in areas where people can't seem to stop smoking, you would want to use signage to communicate to where they are safe to smoke away from individuals who are not smoking, or having segregated areas and labeling them so that only individuals who smoke can occupy that space, and then people who do not can be exempted from areas like that. Now, PPEs, as already said, is at the bottom, meaning that is the last line of defense. But interestingly enough, when we are thinking of protecting ourselves from exposure, it's funny how I'll go to control mechanism, SPPE. And so we end up finding solace in the usage of surgical masks, the N95s, and other forms of respirators. Now, whilst this could be good, again, is the last or is the least protective. And so that shouldn't be our go-to, line of control when we want to protect ourselves. Now, let me tell you how we decided to do the study, particularly among home healthcare workers. So currently we have so many literature when it comes to chemical components of these emissions, either from traditional cigarettes or from electronic cigarettes. And we've had several literature that have documented the impact of exposures, okay? But then when it comes to literature that looks at combined engineer controls or the spatial and temporal distributions from these sources, we have very few. And so we decided, why not? Why don't we do this amongst a cohort who more or less do not have a say in the environment in which they find themselves in, okay? And so we set out to characterize the spatial and temporal distribution of secondhand smoke from electronic cigarettes and traditional cigarettes. And then two, to evaluate how masking practices and increasing air change rates influence exposure to aerosols from electronic cigarettes and traditional cigarettes. So this was how our experimental setup was, okay? This was a lab-based experiment where we employed a commercial smoke generator called an EVT to simulate a smoker's puff profile based on ISO recommendations for traditional cigarette and electronic cigarette. And this was a mannequin mimicking our home healthcare professional and the instruments we used in collecting information. So as already mentioned, this was lab-based. We employed a commercial smoke generator to mimic a smoker's profile. And to mimic exposure scenarios, we employed the silicone-based mannequin at variable distance, and using a real-time monitoring instrument, we collected aerosols generated at these distances. And we considered 4 exposure scenarios: baseline, when no active smoking was occurring, and then 10 minutes of active smoking, 10 minutes of post-burning data collection, and then 30 minutes of data collection when we improved ventilation. And so for our intervention, the effectiveness of masking practices, we looked at surgical masks, the N90 surgical masks, the N95, and the gas respirator, and increased air change rate by comparing our results to unmasked conditions, okay? And so these are what we got. We're going to start off by looking at the temporal profiles. Now, temporal profiles is just talking to us about the behavior of aerosols or the dynamic behavior of aerosols and how exposure tend to change with respect to time and distance, okay? Now on the graph, we have exposures from the traditional cigarette in black and exposures from the electronic cigarette in red. Now for both graphs, during baseline readings, particle number concentrations were almost negligible. However, during active burning or when the EVT was simulated to produce smoke, observe how we have an increase in particle number count, particularly for 1 foot and then 6 feet distance. At 3 feet, we recorded some increase, but surprisingly, they were much reduced compared to the 1 foot and then the 6 feet distance. Initially, our thinking was that the farther you were from the source, the safer you were. But then from our results, it didn't really follow that common assumption. Okay. Now, interestingly, our thinking again was that, or most people would think that, oh, the moment we extinguish the cigarette, then exposure should be fine, or exposure should reduce. But then see something interesting here. In fact, we recorded our maximum longer when we actually extinguish cigarettes. So it tells us that home healthcare workers are still not even safe long after cessation of smoking, okay, because it's even at the site that we recorded our maximum particle count. Now let's see what happens when we improve ventilation. When we improve ventilation, we realize a marked decline in particle number concentration, which tells us that yes, ventilation is a good control measure to dilute pollution or to bring levels down. But then notice how the decline is not immediate. It takes its own sweet time before it assumes baseline readings. And it's all telling us about the tenacious nature of these emissions. Okay. Now, comparing traditional cigarette emissions to electronic cigarette emissions, obviously we realize that these are less than the traditional cigarette. This is just a blow up of what is happening here, so we get to appreciate it. So just like the traditional cigarette at baseline levels, aerosol concentrations are almost negligible. But then we see some marked fluctuations during active burning. The only difference is that for post-burning and increased air change rate, they are almost approaching the baseline readings. And it's all because that usually electronic cigarettes are volatile in nature. And so the moment you exhale, they quickly, or most of them evaporate. And that explains why we have that sharp decline going on there. And I know this is where people will still bring in the argument and say that then again, electronic cigarettes is safe. I mean, we wouldn't endorse that statement because of the fact that it still can impact indoor air quality. It still can also lead to some acute respiratory symptoms. And so what's the take home for home healthcare workers? Exposure doesn't end with us extinguishing cigarettes. We are still at risk of exposure even when cigarette smoking, especially tobacco smoking, has long been stopped. Okay. And then again, some standalone measures such as distancing cannot fully protect us. Now moving on to our size distribution at 1/4. So what this graph tells us that both traditional cigarettes and then the electronic cigarettes produce so much finer emissions, okay, particularly for traditional cigarettes. As you can see, traditional cigarettes is in the magnitude of power 5, whilst electronic cigarettes is in the magnitude of power 3. And some school of thought think that we have more emissions from traditional cigarettes compared to electronic cigarettes because it has both mainstream and then the side stream smoke. And that the side stream smoke significantly contribute to the number of emissions that are produced. Okay. And that is why you have so many emissions being produced by traditional cigarettes compared to electronic cigarettes. And then we also realize that as particle size increases, the particle number concentration decrease, okay? But then the takeaway from this whole projection is that both products produce finer emissions. Now, unlike coarse emissions that when we inhale get trapped in our nostrils, and so some activities like coughing or sneezing can dislodge them and break them out. For finer emissions, they can travel all the way and get lodged in quite sensitive areas in lungs, thereby causing respiratory inflammations or symptoms. And that is what should worry us as home health, should be concerning for us as home healthcare workers, is the sizes of these emissions. Okay. Now let's see what happens at 3 feet. Similar trends are observed. Finer emissions are predominant. Traditional cigarettes are still producing more. The more, as particles become bigger, they decline, the number of concentrations decrease. But then an interesting fact was observed. We realized that from 1/4, traveling from 1/4 to 3 feet distance, there was an increase in particle number concentrations. And so initially we thought that, hey, it suffices to say that the further you were from the source, the more protective you were. But then let's see if that trend is maintained at 6 feet distance. So patterns follow the same trend. Finer emissions are observed, traditional cigarette producing more, emissions concentrations for emissions decline when when particles are increasing in size. However, our particle number counts again, particle number concentration shoot up. So from 1 foot to 3 feet, we observe that trend. But from 3 feet to 6 feet, we lose that monotonic trend. And we really couldn't explain why that trend couldn't hold. The only explanation we could come up was probably at 6 feet, we had some secondary, formation of aerosols coming in. But then we would have to perform further studies to actually confirm or validate these assumptions. So again, we just cannot rely on standalone mechanisms or controls to adequately protect us from these exposures. Moving on to our interventions. As already said, the effectiveness of masking practices and increased air change rates were compared or calculated using unmasked conditions as our reference of baseline lenses. So what we realized here regarding the effectiveness of masking practices when used as a standalone measure and when used together with increased air change rate was that for all the interventions, that was for surgical masks, for N95, and for the gas respirator, which we are yet to see, we recorded some level of reduction. However, the magnitude of reduction was dependent on one, the type of mask that was used, and two, the product that was used. Okay, when the product I mean whether it was an electronic cigarette or a traditional cigarette. So with our surgical masks, notice how during active burning, we have about 70% of reduction of emission from electronic cigarettes compared to about 25% reduction with traditional cigarettes. During post-burning phase 2, we recorded about 50% reduction for electronic cigarettes and about 45% reduction in emission for traditional cigarettes. But then one interesting thing is that when the surgical mask was combined with increased air change rate, see the number, how high our protection was. So for electronic cigarettes, we got about 95% reduction in emission rate relative to about 80% of reduction in traditional cigarettes. Now the difference is glaring. You could see that the N95 just did better or performed better than the surgical masks. Likewise, the gas respirator. Actually, the gas respirator and the N95s perform similarly, but then on the whole, we realized that the N95 was a better option amongst the three. At 3 feet, the trend was similar. We had some level of reduction when using surgical masks as a standalone measure or when combined with increased air change rate. Same with when N95 was used as a standalone measure and when combined with an increased air change rate. And then the same also for the gas respirator. But then we could clearly see that amongst the three, the surgical mask was the weakest. And the bone of contention was actually between the N95 and then the gas respirator. Okay. And the magnitude of reduction this time around was dependent on the exposure phases and more or less on the product. So you could see that for the gas respirator, it outperformed the N95, particularly during the active phase of burning, especially for the traditional cigarettes. So when you compare these two, you could see that the gas respirator did better. But then when it came to the post-burning phase and when combined with increased air change rate, the N95 outperformed the gas respirator. And so we still maintain that the N95 was a better option at 3 feet. Then at 6 feet, the trend still continues. Amongst all three, the surgical mask is the weakest, but then the N95 and the gas respirator are always performing similarly, and then their magnitude of reduction is actually being determined by the exposure phase. But then the N95 is always performing better than the gas respirator. So before we conclude, there are several factors that one will have to consider when selecting these types of respirators or masks. One is the cost, two is the comfort, three is the acceptability, and four is the accessibility. But it's so unfortunate that most often than not, people rush for a particular mask because, oh, this is relatively cheaper than this. So based on our study, we are saying that cost shouldn't be a determining factor as to which mask is chosen over which, okay? And so for us, we would recommend a good fitted N95 coupled with other control measures to offer maximum protection. So in conclusion, it was quite obvious. We are seeing that final fraction dominated with traditional cigarettes producing more than electronic cigarettes. And in terms of persistence, residual traditional cigarette emissions always persisted longer and may require some form of intervention to reduce emission. And in our study, we realized that increased ventilation did that for us. And then again, I can't seem to stress this enough. Standalone measures, we should not deceive ourselves that standalone measures, particularly our PPs, are just enough to protect us from exposures. We will always recommend engineering controls or integrated measures such as our engineering controls and then our PPs to provide meaningful protection. As it stands now, we are advocating and hoping that our smoke-free policy should be updated to include electronic cigarettes so that we enjoy, a comprehensive protection against emissions from both sources. So this project was funded by NIOSH through the Pilot Research Project Training Program at the University of Cincinnati. And a special thanks to all our collaborators who helped in making this project successful. These are some references used. And thank you so very much for your audience. I hope there are no questions. Yeah.
Thank you so much, Judith. Do we have any questions? If you do, feel free to unmute yourself or you can throw it in the chat as well. We do have one question. They say, thank you for the great work. I wonder if you have also studied ways to effectively extinguish traditional cigarettes so to lower the post-burning pollutions.
Could you repeat the question?
Yes. I wonder if you have also studied ways to effectively extinguish traditional cigarettes so to lower the post-burning pollutions.
So I'm sorry to say, no, we haven't found a way to do that. And now that you've brought it up, unless probably you have, I don't see how it's possible because like I said, we are mimicking real world scenarios here, okay? And the moment you stop smoking, I mean, you don't you are not in charge of the emissions that are released into the environment, okay? So I'm yet to see any mechanism that has been proposed to efficiently extinguish cigarettes such that post emissions, probably you didn't get the explanations, or post emissions is when we finish smoking, whatever has been released in the environment is our post emissions. So I don't know how we can modify our active burning phase to limit the number of post emissions we have. I don't know if I've been able to answer your question well. But as it stands now, we haven't or I haven't come across any literature that helps in that regard.
All right, I think that's the only question we had. So again, thank you all for attending today's webinar. Following the webinar, I'll be sending out a survey evaluation. And if you do complete the survey evaluation, you'll receive a certificate for one continuing education credit. So thank you again to our speaker, Judith. And everyone have a great rest of your day. Thank you so much.
Yeah, thank you too. Bye.